Hi friends, welcome to Plexus Ortho. My name is Dr. Kanan Kumar and today we are going to discuss one of the MCQs that we put up a few days back in the Telegram channel. So the question was a 6-year-old girl child presented with a limp and the following radiograph. No previous treatment was done. What is the appropriate procedure now? So if a child is walking in with a limp, important things to be considered in the hip joint are transient synovitis of the hip, right, congenital dislocation of the hip, septic arthritis of the hip, and Perthes disease. These are some of the conditions that you should think about. These are things should register in your mind. Also, if it's an obese child, you can also think of slipped capital femoral epiphysis as well. So when you look at this radiograph here, you can clearly see that something is wrong with the left-sided hip joint. You can also see that the Shenton's line is broken on the left side, right? So you can see that on the right side the Shenton's line is still intact, whereas on the left side it is broken, right? You can't it is not in the same line. So therefore there's something wrong with the left hip, right? And most likely this looks like congenital dislocation of the hip. If you can draw a line through the physis of the acetabulum or the triradiate cartilage that we call, you can see that the head is in the outer and superior. So you can see that the femoral head is in the outer and upper and outer quadrant, and therefore it looks like it is dislocated outside posteriorly and superiorly, and so therefore this is a case of a congenital dislocation of hip or developmental dysplasia of hip, DDH, right? So what are the treatment options? Let us go through in a little bit more detail, but the answer to this question is open reduction and spica application and may require a pelvic osteotomy. So the best answer for this question is an open reduction and spica application, because a closed reduction works in children only less than 18 months of age. So it doesn't work in children who are more than 18 months in age, and a Pavlik harness is used only in less than 6 months children, right? So anything about 1.5 2 years of age and within a reasonable 5 to 6 year range, you can do a open reduction and spica application. You may or may not require a pelvic osteotomy. So the ideal answer to this question is open reduction and spica application, right? So what is the epidemiology of DDH or congenital dislocation of hip, right? The term DDH is used more frequently now than the congenital dislocation hip term, right? So it is seen in it is seen quite frequently. It is seen in 1 in 1,000 population. It is more so in the Western population because they saddle their child in a different way. So in our community, we usually saddle the child with the 2 legs on either side of the hip, and therefore the chance of developmental dysplasia of hip reduces over a period of time, right? So therefore the incidence in our country is far less as compared to the West and other cultures. Remember that. There are 4 F's that are seen with developmental dysplasia of the hip. The first F is that females are more commonly involved in a 2:1 ratio. Remember that. Firstborn children have a higher complication or higher involvement of the hips. Family history is also an indication for developmental dysplasia of the hip. Frank breech also have a higher incidence of developmental dysplasia of the hip because of the fact that the hip is abnormally positioned. Some other conditions that can lead to this include oligohydramnios, less amount of fluid, and crowding of the baby in utero can also cause this kind of symptoms, and pelvic dysplasia of the mother, or some other abnormality where the child is crowded in or compressed in the uterus in utero can also cause developmental dysplasia of the hip. For some reason, left side is more common than the right. This is probably because of the cephalic presentation. The more common presentation causes more compression or deformity on the left side, and therefore the left side is more common than the right side. It is bilateral in about 20% of cases. So 80% of cases are unilateral. Only about 20% cases are bilateral. So in this slide, what you have to remember is the 4 F's. That is, females are more commonly involved. Firstborn are most commonly involved. Family history is associated with this condition. Frank breech is also associated with this condition. Some of the clinical signs that you can find are positive vascular sign of Narath. What is the vascular sign of Narath? Palpation of the artery, femoral artery, is done against the neck of the femur. Once the head and neck is dislocated posterior superiorly, you cannot feel the femoral artery against the neck of femur, and this is called the positive vascular sign of Narath. Alice test is where you flex both the knees up to 90 degrees of the baby, and then you keep a scale or a ruler or something on top of the normal knee or the higher knee, and you can see the difference between these two, and this indicates that the femoral length is apparently shortened. The femoral length is shortened. Why is the femoral length shortened? Because the head and neck of the femur is dislocated posteriorly and superiorly, so therefore it is little shorter than the opposite normal side, and this is called the Alice test. However, if there is a bilateral condition, you cannot use the Alice test, and so therefore we'll go to that, what test we use for that, right? So you can also see asymmetrical thigh folds because of the, you can see there's multiple thigh folds on this leg, whereas there's no thigh folds on this side. So any asymmetry in the thigh folds also indicate some kind of developmental dysplasia or some issues with that. So two commonly asked questions in your exam is about Barlow and Ortolani test. It's very commonly asked, unfortunately, so you have to remember everything about it, right? These two tests are done in the early age, like within 6 months, because after 6 months, once the dislocation becomes permanent, that is not going in or out of the socket, acetabular socket, these tests cannot be done. So this is done at an early age, so remember that. So you can do this test approximately less than 6 months of age, and after that it can be done, but it is once the deformity is fixed, it is difficult to do this test, right? So Barlow, or B for bad, right? So what you're trying to do, if you can see this illustration here, the physician is dislocating, bad, he is dislocating the normally located head. So you're trying to check for the dislocatability. So you keep the knees and you adduct further, so you try to push the hips out of the socket, and that is called as Barlow test. Remember, bad for Barlow, you're dislocating it out. Ortolani test, how I remember Ortolani test is the opposite of Barlow. You bring it from out to in, so you abduct the knees, and therefore you bring the hip joint or the femoral head and neck from outside of the pelvic socket to inside. This is called as Ortolani test. Ortolani is O for out to in, right? Barlow, B for bad, that means you're pushing it out, right? So these two tests are done to see if the hip or the femoral neck is dislocated. If it is dislocated, is it relocatable, right? So in Barlow, you dislocate the hip. In Ortolani, you relocate the hip from out to in, right? These tests can be done at less than 6 months of age. It cannot be done when the child becomes older, remember that. So Klisic test is done for bilateral cases, right? So if patient is bilaterally involved, then you cannot check. They use the Alice test, or even the Barlows and Ortolanis may be a little confusing. Then you use what is called the Klisic test. You place one finger on the anterior superior iliac spine. You place the index finger on the anterior superior iliac spine, the middle finger on the greater trochanter. So what you can see is that normally this kind of angle should be formed, but if these two fingers are moving more towards the perpendicular angulation between the cot towards the cot, then it indicates that the GT has migrated proximally, and this may indicate congenital dislocation of hip. So this is Klisic test. So use to repeat, use two fingers. The index finger is placed on the ASIS, the middle finger is placed on the greater trochanter, and the angle that is formed should be more acute. If it starts to becoming closer to the perpendicular, then it indicates that there is a proximal migration of the head of the femur, right? What are some of the other signs and symptoms that you can encounter in DDH? You'll have a difficulty in changing the diapers. The mother will have some difficulty because she's not able to abduct the hip joint, and therefore she cannot change the diapers very easily, right? Then of course the Alice test we discussed for unilateral cases where there's a femoral length apparent shortening. Klisic test for bilateral cases using those two fingers, index and middle finger. In an older child who started to walk, you will see a Trendelenburg gait in a unilateral involvement, or a waddling duck-like gait in a bilateral involvement. Where else do you see a waddling gait? You see also in pregnant women, because the ligaments are all lax and you have a waddling kind of gait. So waddling duck-like gait is seen in bilateral patients. Trendelenburg gait is seen in unilateral patients. Okay. Ultrasonography of the hip is done to check for the normalcy of the hip joint, right? So there are two angles described. This can be asked in your exams, so you have to be prepared for it. One is called the alpha angle, and this is called the beta angle. So in ultrasound, you can see that this is the acetabulum, right? This is the triradiate cartilage, and this is the labrum, right? So if the head starts dislocating posteriorly and goes somewhere here, then the beta angle becomes more and more larger. So from 60 degrees it may become 80 or 90 degrees, right? Whereas the alpha angle because the acetabulum becomes more and more shallow, becomes acute. So if an alpha angle is decreased and beta angle is increased, then it indicates developmental dysplasia of the hip, right? So you can remember it this way: the alpha is the smaller number, beta is bigger, bigger Greek letter, and therefore beta is increased and alpha is decreased in cases of ultrasonography of the DDH. Remember this. So what are the treatment options available? The treatment options are: in less than 6 months children, you can use something called as a Pavlik harness or a von Rosen splint. Pavlik harness is a kind of a harness with straps which keeps the hips abducted and keeps the hip end located. It keeps it end located. Whereas a von Rosen splint is kind of a POP plaster or a kind of a plastic splint, which also does the same action. It keeps the hips abducted and keeps the hips end located. And so these are the two splints that can be used in a child who is less than 6 months of age. But as the child becomes older, 6 months to 18 months of age, the treatment is close reduction. You do a close reduction. That means you, under anesthesia, you reduce the hip, then you put a hip spica. What is a hip spica? It is a cast which rolls around the spine and then involves both the legs as well. This is called as a hip spica, right? In 6 to 18 months, you do close reduction and hip spica. In 18 months to 6 years, then is when you do an open reduction, because a close reduction also may not work because the dislocation is set in its way, right? So what are the structures that come across or can cause this kind of prevention in reduction? The first structure is a capsule. The capsule can go inside and cause the prevention in reduction, right? The second one is a labrum. Labral tissue, you can see, also can cause a problem. The head will not come back in because the labral prevents that from happening. The third tissue is the iliopsoas muscle. The iliopsoas muscle also goes inside, tendon goes inside the thing and then prevents you from to be able to reduce it. The fourth structure is called the pulvinar, fatty tissue that is present here, which prevents reduction. The fifth one is the ligament, which attaches ligamentum foveum, which attaches to the foveal part of the femoral head. This becomes elongated and prevents you to get reduction. So you have to excise all these tissues before you can get a reduction. That's why you need to do an open reduction after the age of 18 months. The sixth tissue you can see is transverse acetabular ligament. Transverse acetabular ligament. This also prevents reduction. So all these structures have to be excised or released for you to be able to get the head back into the socket, right? So after 6 years, even this may not be enough. You may not be able to. So you need to do some kind of osteotomy to reorient or make the acetabulum bigger or reorient the head back into this thing. So various osteotomies, that is, you make a break in the bone to put it back in its place, is done at a later age, right? So the basic treatment options available are: less than 6 months, you can use a Pavlik harness or a von Rosen splint. 6 months to 18 months, you can do a close reduction. 18 months to 6 year open reduction with or without an osteotomy. After 6 years, you definitely require an osteotomy. So the best answer for the question that we put up was probably open reduction with or without osteotomy, but open reduction seemed like the best option available in that MCQ. So thank you very much. My name is Dr. Kannan Kumar and this is Plexus Ortho. Thank you.